Direct pulp capping. Direct pulp capping is defined as a procedure in which the exposed vital pulp is covered with a protective dressing or a base placed directly over the site of exposure in an attempt to preserve pulpal vitality. Here, the exposed pulp is mainly vital, and the dressing or base directly over the site of exposure. Why it is placed? Because to preserve the pulpal vitality. So, the main goal of the direct pulp capping is preserve the pulpal vitality and mainly not carious exposure. In indications, asymptomatic, no spontaneous pain, normal response to thermal testing, pulp is vital before the operative procedure. So, asymptomatic. Next point is small exposure, that is less than 0.5 mm in diameter. Some book says less than 1 mm is also used in direct pulp capping. Third point is hemorrhage from the exposure site is easily controlled. If it is not easily controlled, maybe an infection is present. Within 10 minutes, we have to control the hemorrhage. Fourth point is the exposure occurred is clean and uncontaminated. Mostly rubber dam isolation. Atraumatic exposure. Fifth point is atraumatic exposure and little desiccation of the tooth with no evidence of aspiration of blood into the dentin. So, definitely there is atraumatic exposure, that is mechanical exposure, no carious exposure. So, these are the indications when we use direct pulp capping. Asymptomatic, small exposure, these are the things. Factors affecting direct pulp capping. Local factors, mainly area of the exposure, where it exposure occur, and size of the exposure, mainly less than 0.5 to 1 mm, and bacterial contamination. Definitely there should be not any contamination, and duration of exposure before treatment. Let's see this point. And carious versus mechanical exposure. Definitely there is no carious exposure is present, and micro leakage. These are the local factors affecting the prognosis of the direct pulp capping. These are the techniques where we use these procedures. If exposed pulp is size of the exposure, it is small, that is 0.5 to 1 mm, we go for direct pulp capping or Cevex partial pulpectomy. If it is large, 1 to 2 mm, we go for complete pulpotomy or pulpectomy. Duration between exposure and treatment, that is up to 48 hours, Cevex partial pulpotomy is done. More than 48 hours, pulpectomy or complete pulpotomy procedure is done. Duration of hemorrhage, that is less than 10 minutes, go for direct pulp capping or Cevex partial pulpotomy. More than 10 minutes, that is go for complete pulpotomy and pulpectomy. So, these points when we go for direct pulp capping, that is small exposure and less than 10 minutes, we have to control the hemorrhage. These are the important points we have to remember when we go for direct pulp capping. The objectives of direct pulp capping is increase the tertiary dentin formation and reducing the inflammation. And here we have to remember some clinical points before doing direct pulp capping, that is direct pulp capping is not clinically recommended in the case of carious pulpal exposure. This is the important point, not clinically recommended in cases of carious pulpal exposure. A minimum thickness of 1.5 mm MTA is recommended to be placed over the site of exposure. So, if we place MTA, it should be 1.5 mm, definitely we have used. And third point is poorly indicated in deciduous dentition, mostly it is used in the permanent dentition. Next, what are the agents we used? Mainly calcium hydroxide and MTA technique. Caries removal, we use number 2 size carbide bar and spoon excavators are used. So, these are the important point we have to remember in direct pulp capping. So, small exposure and accidentally exposure, we use this method.